This is a 43-year-old woman who had a long history of asthma, and she came into hospital with a sort of 3 months of increasing lassitude, tiredness, increasing breathlessness on exercise, and got worse in the week prior. She had a temperature, cough, ease. She was given all the sort of standard anti-asthma stuff on the wards, and then they added in stuff, and she wasn't getting better, so she came to the ICU. She was wheezy and tiring. Her chest actually was just clear, and on examination there were sort of wheezes and crackles of appeals. Okay, and she became increasingly tired within 3 hours. She had some BiPAP, failed, she needed tubing. She was ventilating okay, but, a bit odd for an asthmatic. It was very easy to ventilate her. Because people should be having higher aggressions and long expiratory time. It wasn't the case. Yet she was leaning a very high amount of oxygen. There was, on a repeat X-ray, a bit more shadowing. I think she had some pulmonary edema, or was it ARDS? She was tachycardic. There was a bit of right axis deviation on her ECG, but that was it. And they were her numbers. So she had a good blood pressure. She was tachycardic. And the CDP was 14. Okay, what would you do now if you didn't have any flow monitoring? Again, no shaming, saying anything, because that's it's just the challenge of what you do in this situation. Yeah. Any offers?
We don't want this is
Focusing
point of
okay.
yeah, ultrasound.
How good is focus?
That also again using it and
Yeah, that's the problem. So I think Poken's in the right hand and brilliant. Unfortunately, the number of times people get it wrong. So if it's done well by somebody experienced, and it's an absolutely great technique. I think unfortunately, often number of times you've had, I'm not good at it, so I don't claim expertise. So the number of times you go, oh, this is what's going on, and then actually for something else is going on. So it very much, I think it's a lovely diagnostic as a monitor. So and if the walls are collapsing, then it's like either, the patient probably be fine. But again, in assessing a 200 ml fluid challenge, has it made things better or worse? I defy anyone who does poker. So unless you're doing the Doppler component and looking at sort of stroke distance to actually say, it's a meta. So wonderful diagnostic in my hands, absolutely. Not so great for monitoring.
Is there anything on blood gas amounts?
Acidotic.
Is she on neuromuscular pain?
No, not at the time, no. Well, she'd had soon after intubation, that wore off, but no. CTPA, okay, but we'll come back to that in a moment. Yeah. What are you thinking on?
Finally, self-awareness.
Yep. Again, good possibility on the list of differentials, absolutely. Any other thoughts? How would you manage the hemodynamics? Are you not fast a little bit? The lactate's a little bit high. Heart rate high versus blood pressure's good.
She's a cheese on the solid.
Yes, that is too much. Could have carried it out. Yeah, could have good exactly. It could be. Then we're not finding this check. And the CBP's 14.
Yeah. You could try a cautious flow chart.
If we could try a cautious flow chart and see the embed. Yeah. All of these things. And this is years ago, and this was actually with the nurses. I didn't have a camera on my mobile phone at the time. Now everyone had the evicted. The nurse actually very kindly took some photos and a little video for me. Okay, that was the Doppler. I'll show you the other numbers in a second. Again, you get rescue flow time of 230. It's threat warning absolutely very low, 33. The people off these 73, which isn't great. For a youngish woman.
And we see the swing as well.
And yes, it's not huge, but they're out right over the swing. Yeah, there's a better sweetness. And as I said, she didn't have high airway pressure, so yeah. Okay. So now with that, what would you think? Try some fluid challenge. Okay. So they were, when we put the probe in, they were the initial measures, and that was after fluid. So it was 21 mils. And then this is post-limit, so it was 210, and we got it up to 230. So it still looked empty, didn't it? But the blood pressure and the CVP, this is after the CVP was even higher. And tried a leg raise, straight leg raise is a fluid challenge. I like getting nitrate boluses, because I can put it the nitrate test. So you get this short-lasting sort of dilation. And if they're well filled, cardiac output goes up. And people just opening up circulation to allow a sort of flow of blood through the circulation. But if it crashes, it suggests that the heart's empty for whatever reason. And I agree. You know, is she obstructed? She was acting as if she was obstructed, thinking about a PE. She was getting more and more unstable. So yeah, we thought, could this be a PE? And got an urgent echo. At the time, we didn't have our own echo, but so the cardiology reg actually, and it'd be kicking and squeak just out of hours to come in to do an echo. And again with the nurse's phone, the examiner, blocking, so you can see it here. You can see it is plopping in and out of the mitral valve, mitral myxoma. And she had pulmonary hypertension. Treatment, management, surgery. And at the time, we had cardiac surgery on site, and so she was stabilised overnight and then went to Piers at first thing in the morning, which was Friday the 13th, as it happens. And that is actually hers. So the anaesthetist who did the case took a picture. It was 65555. What chunky. There's the picture. And no wonder it was blocking the mitral valve. Pardon?
There's no space left.
No space there, exactly. And initially she was a bit rocky for a few days, but then actually made a full recovery. She said, "Oh, I feel better." No, kind of you. Despite having,